You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for March 29th, 2019. This week, AF ablation, cabana, eggs, alcohol and atrial fib, and treating atrial fibrillation after ACS or PCI. First up, I wanted to discuss the Avatar AF study which was presented at European Heart Rhythm. Oh boy, this study is a hot potato if you are an EP. Investigators from Imperial College in London have designed, conducted, and presented preliminary data on a provocative study of AF ablation. Their premise, which is shared by the sponsor, Medtronic, is that the health of populations would be enhanced if only we could offer AF ablation to more patients. Of course, I disagree with that premise, but no matter. Now, one reason AF ablation is not used more often, at least in some countries, is that it is expensive and technical and it requires an electrophysiologist with training. But what if AF ablation could be made more simple? So Avatar AF tested three strategies. About 100 patients in each arm. 100 patients got conventional cryoballoon ablation, 100 patients got antiarrhythmic drugs, and 100 got this abbreviated cryoballoon. There was no mapping of the pulmonary veins, no checking for isolation, just put the cryoballoon in and freeze twice. Now, that wasn't the only twist of this trial. Here is another. Instead of measuring the silly endpoint of 30 seconds of AFib, they simply measured a hospital episode for any reason, emergency department or inpatient stay. Now, the results are that both ablation arms reduced hospital encounters far more than antiarrhythmic drugs. That is not new, but sit down for this, or if you're driving, pull over. 23 patients had a hospital encounter in the simplified ablation arm versus 19 in the conventional arm, not even close to significance. That is, willy-nilly ablation was as good as electrophysiology-guided ablation. Now, as a person who spent years learning how to perfect the technique of isolating pulmonary veins, my gut reaction was to holler that this is hogwash. Of course, only electrophysiologists can ablate AF. But a rule of thumb is if you are emotional about a study, either good or bad, you should consider this a warning to stop and think. So, taking a deep breath and thinking, I find this a super interesting result. First of all, they use a great endpoint. A hospital encounter is an outcome that matters far more than 30 seconds of AFib. Second, the fact that willy-nilly ablation is as good as an electrically guided one raises a couple of possibilities and questions. One question, is the cryoballoon ablation sufficiently reproducible in its ability to isolate the PVs that really checking is not necessary? Another possibility is that willy-nilly ablation doesn't isolate the PVs as well, but it doesn't matter. Now that provokes because prevailing thought is that successful AF ablation requires durable isolation. But maybe prevailing thought is wrong. I mean, that's not ever happened before. Now, this is just an abstract. Review of the full paper will be important. And the numbers are small and follow-up is limited. We may see differences after 1 year. And finally, this is most important. I utterly oppose lowering the bar to AF ablation, whether it is EP-guided or willy-nilly ablation. Yes, I believe AF ablation has a role in AF management, but it should be used only by expert clinicians who have sufficiently removed fear from the decision and address the many potential causes of AFib. Now, this takes time, human relationships, and you have to pay attention to hard-to-treat issues like obesity and alcohol use and sleep-disordered breathing, to name only a few. And Medtronic's push to move AF ablation outside the realm of EP reminds me of device manufacturers' move to push ICD implantation to non-EPs during the period of irrational exuberance after the ICD trials. This was a bad idea, not because implants required special skills, but rather because managing patients with arrhythmia is not about the procedure. It's about the clinical knowledge that comes with training. I could train you to implant an ICD or do a cryoballoon ablation in a matter of weeks, but it takes years and lots of mentorship to manage people with chronic conditions like arrhythmia. Second topic today is Cabana. The Cabana trial started off with an audacious goal, and it was to show AF ablation made people live longer. The original primary endpoint was simply mortality. But slow enrollment and lower than expected event rates caused investigators to expand the primary endpoint to a composite of overall mortality, disabling, stroke, major bleeding, and cardiac arrest. Cabana enrolled about 2,200 patients, median age 68, CHADS-VASc 3, at 126 centers in 10 countries to an ablation versus antiarrhythmic arm. Notable was that these were ablation centers with ablation proponents. JAMA published the study. Trialists powered the trial, expecting 25% treatment crossovers. Now the main results. Over a 4-year period, the primary endpoint occurred in 8% of patients in the ablation group versus 9.2% of patients in the drug therapy arm. This was a 14% relative risk reduction in favor of ablation. The confidence intervals ranged from a 35% reduction to a 15% increase, and the p-value was non-significant. Of course, this was the intention to treat analysis, but Cabana had lots of crossovers. 9% of the patients assigned to the ablation arm did not have an ablation, and 27% of patients assigned to the drugs crossed over to ablation. Now, that fact tempts you to look at the as-treated analysis because, let's just look at the outcomes in those who actually got the procedure. And here, ablation looked better. But you can't do that. When you break the ITT, the intention to treat, you induce bias. That's because the point of randomization is to balance all the confounding variables, those that are known and are able to be put into a data sheet, and those variables that are unknown. And when you look at the as-treated analysis, you can't tell if those patients were similar. In fact, my colleague Rod Gimbel pointed me to the Cabana appendices. Here, you find characteristics of the patients who crossed over from the drug arm to the ablation arm versus those who stayed with the drugs. And there were significant differences. Significantly more patients in the drug arm who crossed over to ablation had less severe heart failure and more often had paroxysmal versus non-paroxysmal AFib. This means sicker patients stayed with antiarrhythmic drugs and healthier patients went with ablation. So this fact, maybe not ablation, may explain the better results in the as-treated analysis. The short story with Cabana, the bottom line, was that it was an inconclusive trial. We can't say AF ablation improves outcomes. Now, Cabana investigators also published data on AFib episodes and quality of life in a separate paper, and it showed that ablation over drugs improved quality of life and ablation reduced AFib episodes. The problem with reduction of AFib episodes as an endpoint is that AFib on the ECG is a surrogate that has some correlation with quality of life, but the correlation isn't perfect. For instance, some patients still have AFib after ablation, but they report feeling great. Now, the main problem with looking at quality of life outcomes is that the patients know their treatment. There could be a huge placebo effect with ablation. Remember, the bigger the intervention, the bigger the placebo effect, and AF ablation is surely a big intervention. Red pills have more effect than white pills. Big surgery has more effect than small surgeries. To really know the effect of AFib ablation on quality of life, you need a placebo-controlled trial with a sham procedure. Who would have thought stenting a 90% LAD would not relieve angina any better than a sham procedure? Now, third topic, the infamous JAMA egg study. Only a few days before ACC, JAMA published an observational study along with a press release and teaser for mainstream media that eggs are associated with heart disease risk. And boom, all the media outlets covered it. The study's altmetric score is off the charts, over 3,000, and JAMA earned greater than 23,000 page views. And I'll tell you, this boondoggle is sad for science, embarrassing for JAMA, and it further erodes any semblance of credibility that mainstream media had. Last year, I reported on what I thought was the most important scientific paper of the year. It was from Brian Nosek and colleagues at the University of Virginia. I will link to it in the show notes. Nosek and his colleagues showed that a single simple question from a single large data set can yield disparate results, and these depend on the way the data is analyzed. That shocked me. Nosek found that 29 teams of researchers chose 21 unique ways to analyze the same data. 2/3 of the groups of the analytic methods yielded statistically significant results, and 1/3 did not. Now, whenever you read big observational studies like the egg study, it's good to keep in mind how fluid the results can be. John Ioannidis once said in a lecture that in observational epidemiology, any result was possible. In the egg study, you have self-reporting issues, you have confounding, you have the fact that figure 1 shows that the relationship goes away for coronary heart disease with adjustments for fish, poultry intake, a point made by an economist on Twitter. I would also make the point not to be fooled by the large numbers of people in the study. Almost 30,000 people in the study. Big numbers are useful for showing small effect sizes, say, in RCTs, but big numbers do not correct for systemic biases. I think the danger in these sorts of studies is distraction. When you pay attention to flawed data, you're less apt to notice important data. But as long as the business models for journals and media is page views, I think we're going to see more of this, sadly. Fourth topic is alcohol and atrial fibrillation. Now, numerous observational studies associate alcohol intake with AF. So, doctors recommend to patients that they cut back on alcohol if they have AF. At ACC, the EP team in Melbourne, Australia, added to the strength of our recommendation on alcohol with an RCT, a really elegant RCT. The alcohol AFib trial tested the hypothesis that if you were a moderate drinker, abstinence would help your AFib. This was not an easy RCT to recruit for, as moderate drinkers had to be randomized, and there was a 50% chance to be randomized to the no drinking arm. They screened 700 patients to get 70 patients in each arm, abstinence versus normal intake. Only 61% of the 70 patients in the abstinence arm completely abstained, but most patients in the abstinence arm cut their intake by greater than 70%. And alcohol abstinence worked. Both primary endpoints, which was time to AF recurrence and AF burden, significantly improved in the abstinence arm. And other good things happened too. Abstinence led to lower blood pressure, more weight loss, and decreases in left atrial size as measured by MRIs. The study was presented as an abstract at ACC, and we'll have to see the paper. But this is important data helping the care of patients with AFib. Also, this was unfunded investigator-initiated research, so congrats to the Melbourne, Australia team. Final topic today is the Augustus trial. Augustus tested the question of bleeding in atrial fib patients who have an ACS or PCI. It tested apixaban at standard doses versus warfarin and aspirin versus placebo in patients who received a P2Y12 inhibitor, mostly clopidogrel. Augustus used a 2x2 factorial design, which is useful for testing two questions within a single trial. It had about 4,600 patients recruited in 33 countries. The primary endpoint was major bleeding. Now, this was a bleeding trial. Secondary endpoints include death or hospitalization or composites of ischemic events. And remember, in a 2x2 trial, there are 4 treatment groups. So first set of results is that 10.5% of the apixaban group had a major bleed versus 14.7% of the warfarin. That's an absolute risk reduction of 4.2%, which is a lot. And of course, it met criteria for both non-inferiority and superiority. So in the second comparison, the antiplatelet comparison, 16.1% receiving aspirin had a major bleed versus 9% receiving placebo. The absolute risk reduction, 7%. And that too was a really big difference. And the number needed to harm with aspirin for bleeding was 14. Now, the percent of patients with primary bleeding outcome was highest among those receiving a vitamin K antagonist and aspirin, and lowest among those receiving apixaban and placebo. As for secondary endpoints, death or hospitalization was significantly lower by almost 4% in absolute terms for apixaban versus warfarin, but in the aspirin versus placebo arm, there was no difference in this endpoint. And then for various ischemic events, which the trial, importantly, was not designed to answer, remember, this was a bleeding trial, there was some nuance. In the apixaban versus warfarin comparison, CV death, stroke, MI, stent thrombosis, and urgent revascularization, they did not differ much. But in the aspirin versus placebo, there were small but statistically insignificant increases in MI, stent thrombosis, and urgent revascularization in the placebo versus aspirin arm. In fact, stent thrombosis were nearly double when dropping the aspirin, 0.5 versus 0.9. And another caveat, patients were not enrolled in the trial until a mean of 1 week after the index event. That's a period when they were receiving aspirin, so Augustus does not inform the decision about early withdrawal of aspirin. So it looks like when using anti-thrombotic therapy with both anticoagulants and antiplatelets after PCI or ACS, apixaban is preferred over warfarin. And if the risk of stent thrombosis is low, dropping the aspirin and using apixaban plus clopidogrel will reduce bleeding. Couple caveats, and these were noted in the news story. If you want to use triple therapy because you feel aspirin is important, say because your patient is very high risk for stent thrombosis or for ischemic events, the study shows that you're better off using aspirin with apixaban than aspirin with warfarin. Another thing mentioned in the news story is that the trial doesn't say double therapy is necessarily the best option for all patients with AFib and recent ACS or PCI. Remember, the trial's design wasn't set up to make that conclusion. So finally, Augustus aligns pretty well with previous trials of DOAC versus warfarin in the post-PCI setting. When combining with clopidogrel in these patients, DOAC looked to be a better choice than warfarin. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. And remember, if you like this podcast, please consider subscribing or writing us a review so that others can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.